I think one of the key challenges right now, if you're migrating from fee-for-service to value-based care in smaller practices, is there's no clean cutover, right? It would be too frightening to cancel all of your contracts and move to one. So we see this evolution where people put their toe in the water and are 90% fee-for-service, 10% value-based care. The trick there, Mendel, is that
ladies and gentlemen, welcome back to another fabulous episode of the Healthcare Trailblazers Podcast. Here today with the wonderful Kevin Coloton. Kevin is the CEO of Curation Health, founder and CEO of Curation Health. And so excited to hear all about it. Kevin, thank you so much for spending time with us today.
Thanks for the opportunity. Great to be with you.
Let's take a step back. Where did you grow up and how did you get into healthcare?
Yeah, I grew up on the border of the New York, Canadian area and upstate New York. It's called Canton, New York, small town. And my parents were both pharmacists. So all of my connections in my youth were healthcare oriented. I was an athlete in my youth and was injured frequently. Spent a lot of time in the trainer's room getting recuperated, and chose a path to physical therapy. So that's how I got connected and stayed connected in healthcare.
No way. What did you play, sorry? What sport?
I was an endurance athlete, so Nordic skiing, triathlons,
Wow.
Long distance running. I started, my youth was ice hockey, right? If you're on the Canadian border in New York, that's a given. But
yeah, I did about 10 years in Toronto, so about 2 hours, maybe 3 hours from you.
Yeah.
Yeah, that's a rough part to grow. I mean, it's a fun part, but a lot of snow, definitely a lot of snow, a lot of shoveling, a lot of that. I got some good friends in Buffalo, and I remember, I don't know if you did a lot of ice fishing, but one of the most magical experiences I've ever had was I was probably in 9th grade, maybe 10th grade, and we went out on Lake Erie, I think it was. That's by you, right?
Fairly close, yep.
Yeah, so we went out on Lake Erie, and but it's big enough where you kind of take one of these special cars and you go all the way out, and then there's little huts, and they're warm, and they're heated, and there's a little hole in the ice, and you go and you go ice fishing. But what was so eerie about it, it's funny, it's Lake Erie, is that you were so far out that all you could see is the lake, but the lake was frozen over and it was white, and the sky, because it was winter, was also white, and so you have this bubble of just you can't tell where heaven ends and earth begins kind of thing, you know.
That's right. You're sitting in a cloud. Yeah, I know that phenomenon. Absolutely.
I gotta get back there. But I digress. And so physical therapy, that's cool. I do a lot of physical therapy myself. Big fan. And so how did you get from were you working a job? Were you a physical therapist? Were you running a business?
Yeah. No, I was a physical therapist in the Hopkins Health System. And then I did that for a while, and then I was introduced to entrepreneurship. Some friends and I, when I was in business school, started a company doing online healthcare education. Transparently, we didn't do very well. And I learned a lot, including that I had a lot to learn. So I went to the advisory board company from there, had an opportunity to be part of their business development team during the public offering period. And that was a great experience. DC based, then went back to Hopkins as a hospital administrator, and that was an amazing experience. And then did management consulting for a while, retail medicine for a while, and then was part of a founding team for a consulting practice in DC called Clinovations. Did that for a few years. Great experience, great people. Then we sold that company to the advisory board company.
No way.
Yeah, so now that's part of Optum's portfolio.
And then Optum bought the advisory board.
Yeah.
Get out of here.
Yeah, it was a great journey, and it was a great.
Did you roll all the way up? Did you ride it all the way?
I actually exited before Optum acquired the advisory board to start working on what we're doing now, which is Curation Health.
Nice. That's awesome. Okay, so quite the journey. Health system, you glossed over it, but there's quite some stops there. Health system administrator, and then being part of a company that goes, that's really fantastic. And so, what is Curation Health? Let's start there.
Yeah, we're focused on value-based care, the transition from fee-for-service to value-based care for primary care and some specialists in the outpatient setting. So our focus is making that turn safer, more sustainable, and easier for providers looking to migrate to value-based care contracts and sustainable success in those programs.
Okay, this is going to be really, really interesting. So your clients are small mom and pop primary independent docs that are looking to move over. Is that what I'm hearing?
So they can be included in our ecosystem. Our primary client base are large integrated delivery networks, think large health systems, as well as health plans looking to support providers in that journey to value-based care. Many times, though, they're part of a clinically integrated network, and we get the opportunity to serve smaller and larger practices in that way.
Yeah. Okay, cool. Because people always ask me, like, when I talk about value-based care as a payment model, and they're like, okay, but who transitions over? It's like, well, the system, a large system, you have to have volume in order for it to make sense. And so I thought you were going to go down the path, and if we can go down this path, we'd love to hear how possibly a transition to value-based care is applicable to just your standard independent doc outside of joining an ACO or something like that and doing kind of a smaller initiative.
Absolutely.
Can we talk about that? Okay.
Absolutely. Happy to. Yeah. So specifically, I think one of the key challenges right now, if you're migrating from fee-for-service to value-based care in smaller practices, is there's no clean cutover, right? It would be too frightening to cancel all of your contracts and move to one. So we see this evolution where people put their toe in the water and are 90% fee-for-service, 10% value-based care. The trick there, Mendel, is the transition, right? So where do you put your energy? Where do you put your investment? Because ultimately, right or wrong, they require a different workflow. In a fee-for-service environment, typically you're the catcher in a baseball analogy. You're waiting for the patient to come in. When they come in, they introduce to you what their priorities are for that particular visit. You engage with them, you address those priorities, maybe touch on one or two others if you have time, then you move on to the next time they come in. In the value-based care model, you're quote unquote at risk for their outcomes. So it's a very different engagement, and you're more of a pitcher, reaching out to them, bringing them in to address a broader set of priorities than just their acute reason for visit today. And it also takes a different approach to manage the complexity of those differences, right? Instead of managing a sinus infection today, which is acute and a real problem for a patient, you're managing their 3 or 4 chronic conditions, their lab values, their medication reconciliation, there's a lot more to it, and a different workflow is required. And that typically trips up these smaller practices trying to move into that model. Is they're time pressed, right? It's one of the hardest jobs in the world to manage the complexity and the scheduling constraints and the intensity of being primary care or specialty practice in an ambulatory environment, especially in an independent setting. You don't have the resources and the infrastructure associated with a larger group supporting your practice. So that's a daunting transition. I think a lot of people over time are trying to figure out, how do I migrate that way? And a lot of them are interested in joining other groups or larger, I think we touched on it earlier around ACOs, or there are other ways to participate that have the scale infrastructure support required, because it does take some capital to get started in moving to that direction. But the key is think big, start small. How do you simplify what is different around these two workflows and try to find ways to address them?
Yeah. That makes a lot of sense. So what are they? What are the ways?
So a couple ways is to think about simplicity, simplicity of information, simplicity of workflow. I think a lot of people feel like they would need to put together this big effort to do value-based care. I've seen it done on 3x5 note cards, and I'm not making it up, where providers had a note card with each patient's key priorities, and they'd flip through them when the patient arrives. So you can do it in a low-tech way as long as it's not at scale. Once it gets to 2,000 lives trying to manage value-based care, that gets really complicated without technology support to enable efficiency and scalability. But on a small scale, I've seen it done quite well, where just simple approaches to try to manage the comprehensive nature of patients' needs, or partnering with others to get better data insight and focus their attention on the things that really make the highest impact. You can also start small by just conducting some fundamental visits first. Focus on annual wellness visit and use that as an opportunity to engage your patients at a different level, and get a comprehensive snapshot view of their priorities, their clinical needs, and what is keeping the patient up at night from a clinical status, and use that as your launching off point to manage their care across the remainder of the year, for example.
Yeah. So when you mention complexity, from a workflow perspective, you're spot on. You can take it small. You can find kind of your highest areas of utilization that are coming from your highest risk patients, and just deal with those, right? Just like redline those 15 patients and start there, right? But my first question would be around the actual, okay, well, fee-for-service is really, really simple to understand from an economic perspective, especially given the fact that most doctors are by no stretch of the imagination a business person. And so it's really simple. I do X, it spits out CPT code Y, and I get paid Z, right? And so my first questions would be, well, if like, where do I start from? Who's paying me? What are they paying me for? How do I start that transition from a contracting perspective? And so what would be your ABCs for that process?
Yeah, I wish that was easier. You're really a challenging component of this journey. What we often find is, in particular markets, regional and national health plans have a real interest in moving providers from fee-for-service to value-based care because they're being incented and pressured to do so. And they are very willing in many markets to support that migration and support the insight generation, where they can provide data and information on the key priorities. They can incent appropriately for value-based care activities associated with practices that have economic incentive tied to them. So if you're conducting a comprehensive visit, there could be an economic benefit associated with that activity, not the outcome necessarily, but the activity associated with delivering a value-based care-oriented visit. So I would encourage these smaller practices to get a better understanding of what's happening in their marketplace. Are they members of a contract currently that's fee-for-service with a health plan that could have elements of value-based care added to it? We've seen a real appetite from the health plan side to invest in the success of providers in their community to help them ultimately make that journey and that change as well.
So back to Curation for a moment. So is it a consulting company where you help hold people's hands and walk them through the process? What is the service?
Yeah, we're a technology company in our own mind, but many of us are former management consultants, so you never fully leave the solution services world.
But we're out of the consulting.
That's right. That's exactly right. I find myself pontificating many times on what could be and what workflows need to change globally. But it's a real passion, right? Because ultimately, at the end of the day, often we are approaching this problem from a technology perspective or an entrepreneur perspective. And what we're frequently caught up in is the potential. This new tool can unlock so much additional value for a provider. This new analytical insight could be incredibly valuable for a doctor delivering care. This list of activities could be super helpful. That innocence and that true belief in trying to help often has a negative impact on the end user. So let me give you an example. I was at a national conference last year where a health plan strategy executive in front of a very large conference room said, I have two strategic priorities this year. The first one is to deliver this massively valuable data set to the doctors in our community so they can elevate care. My second priority is to remove provider abrasion. And those are disconnected. A massive data set to someone that has no time, is overstressed, is dealing with massive complexity, decompensates their ability to deliver the result intended. So we need to come to terms with this disconnect of the potential of these tools and this data and this value and big data and huge analytical efforts with an end user that has 6 minutes with the patient, 7 minutes with the patient, maybe 10 minutes with the patient. They have a long list of things they need to take care of anyway, and the nurse is knocking on the door for something else that needs to be done. We need to take the opposite approach of simplifying insight. If you have 10 minutes, what are the 3 things the doctor can do today to elevate the health and outcome of that patient, and focus their attention on those 2, 3, or 4 things? Not on the 85 things that could be done in the EMR, but on the 3 things that had the most impact to the patient's outcome. So I say that by way of a backdrop because that's literally our philosophy. So we are trying to analyze that massive data set, use really high fidelity analytical tools, AI, and other technology efforts to simplify it and prioritize that data before a clinical interaction happens, say 3 days before a doctor is going to see a patient or a physician extender is going to engage with a patient, and have that ready for, if they use humans in the pre-visit review process, we pre-analyze all the information and deliver them an organized list of things to validate. That's all before an interaction. We then deliver those insights typically through the provider's preferred workflow, which is often the EMR. So we're a certified partner of many of the EMR platforms because we want our insight to delivered into their convenient workflow. There's a high adoption if it's easy to get to and easy to use and fully integrated. Then once that clinical interaction happens, we enable a medical coder to review and be a backstop for the provider as part of a care team to say this meets compliance or it needs some work. It might need some more documentation or enhanced documentation to justify a code or meet MEAT and Tamper guidelines. So that's what we do, is pre-visit analysis of information to distill down at a patient level what's most important, deliver it at the most convenient way for a doc, and then post-visit enable a medical coder to be part of the care team to ensure the compliance and integrity of the documentation and coding. We do that to help providers have a more sustainable workflow associated with their value-based care efforts.
Yeah. Where's that point of crossover? Where's the point in what's the journey from being in a fully fee-for-service world over to value-based care? I would imagine the most tension is when you get towards the middle. What does that look like for the doc? What's the highest point of pressure?
Well, I think we've seen every graduation of that percentage, right? We have clients that are, and I'm not exaggerating, 95% fee-for-service, 5% value-based care. We have clients that are 0% fee-for-service, 100% value-based care. So that continuum is very wide. And they need different things at those different levels. What we aim to do, which is a little different, is to just create 2 workflows for those groups in the middle, right? Or even if you're 95 and 5, right? If you're 95% fee-for-service, 5% value-based care, the goal is to not have to provide the cognitive load. You don't want to deliver that cognitive load to the patient or to the provider to figure out, is this patient in front of me a value-based care patient or a fee-for-service patient? That should not take cognitive load, right? Wear a navy blue suit every day. Take away a decision if you can. So our orientation, regardless of that continuum, is there's only 2 workflows. If it's a fee-for-service patient, just do your normal EMR documentation and coding. If it's a value-based care patient, you'll typically see the Curation Health workflow pop up. So the doctor doesn't need to make a determination, which patient is this? And they candidly don't even need to make the determination of which value-based care contract is this, because all we're presenting is Mary Jones is coming to see you today and has these clinical priorities for you to focus on. as making it as simple as possible. That's the goal. And we don't want to have it be financially oriented. We want it to be clinically oriented. Mary Jones needs your help. These are the priorities that are based on the data and analysis. If you agree, accept. If you don't, dismiss. And if you don't have time, defer. And that will be present for you the next visit you see Mary Jones. That's our mindset with this, is trying to take away decisions that don't need to be made, to focus the provider's expertise and superpower on addressing those clinical priorities that maximize the health and outcomes of the patient.
So CMS has made it pretty clear that we're doing this. They famously announced about a year, maybe 2 years ago, that they expect everyone to be in some sort of value-based care arrangement and relationship by the year 2030. You understand the complexities of that transition. How practical do you think that is? Let's start there.
Oh, practical. That is it's plausible. I will submit. I submit it's plausible, in that you still deliver the same care to the patient. The difference is in your orientation and the documentation and coding. As a technology industry, we should be able to contribute effort to make it easier to document and code. Full stop. Like, that's something we should be able to deliver on. The core tenet is the same. I am a provider engaging a patient to elevate their health and outcome. The administrivia associated with getting appropriate documentation, coding, reimbursement, contracts should be able to be simplified, hopefully automated, far more than we are doing in 2024.
Yeah, that'd be nice. Right?
It would be nice. The big orientation difference is a provider cultural shift from I'm waiting for the patient to come in to I'm engaging with this patient across the year. That is a big workflow orientation shift. And we help our clients as they're moving towards that orientation change with change management support, and try to help them with training and education and provide them as much help as we can, because that's the big workflow pivot that needs to happen. And that's a whole infrastructure swap. If you really step back and say, what's different between those two? It's almost everything is different, from a fee-for-service foundational activities to a value-based care. You probably shouldn't have 5-minute visit slots if you're doing value-based care, right? It just doesn't make sense. You probably shouldn't have 62 patients if you're doing value-based care. You shouldn't have your team oriented on these activities. They should be oriented on these activities. We should have a call center reaching out, not receiving, right? The whole infrastructure will need to be migrated over time, but not all of it needs to be a full shift immediately. But we need to prioritize what investments we need to make from an infrastructure perspective to help providers be successful in that change. But it's 2024 and you're projecting 6 years from now. So my hope is, sometimes things move slow, sometimes they move very fast. My hope is if we keep it simple and focus on a prioritized list of what we should optimize, we'd be able to get there and help providers be successful in that model. I truly believe, I wouldn't be doing this if I didn't believe this, but I truly believe it's a better model. I won't say perfect, but a better model than paying for, the amount of times we do things and the intensity we do them. Paying for, helping elevate the global health of a population of patients is just a more appropriate and long-term sustainable model.
So at Curation, what are some things that you're proud of, and what are some goals for 2024?
So proud of, I think first and foremost is our team. We've got a really good team. A lot of the team has worked with me for a long time, even in previous companies. And that's a really important part for me is to show up to work every day with people I enjoy working with, solving problem. The second part is we hire people that truly believe they're doing something meaningful. We're not just building a tool that reports things that somebody may or may not use. We meaningfully want to invest in helping providers do the ultimate act of helping patients get their health in order and elevate their health over time. So that's probably what we're most proud of collectively. We've had the opportunity to serve really impressive organizations and small physician offices. We love both, and both we take a lot of satisfaction and pride in. I think the last thing that I would mention is we've made a measurable impact in our clients, in their ability to sustain their work. Anybody can do value-based care and fee-for-service intensity for a short period of time, but this is definitely a marathon, not a sprint. And having sustainable success over time is something we're excited about, and we celebrate with our clients. And they show us the appreciation by continuing to do more value-based care over time, which is awesome, because if that's where we're trying to get to, the fact that they're pivoting more and more each year to that is a great thing. And the second thing you mentioned was, it was what we're most proud of, and I went deep there. What was the second component? Goals. Yeah. So so as we started our journey, we really started in earnest in 2020. Nothing like starting a company in January of 2020, the month the pandemic began. So we had an interesting start to our exciting journey, but we were able to quickly optimize our system, invest energy during that period of time to get our technology and infrastructure in order. But we largely served providers and large complex providers first for a really important reason. I think you're picking up on my obsession around end user workflow. In management consulting, I worked for a firm that had a motto: we ride in the delivery truck with our clients, which means we actually understand what they need to win. And so we started with provider first, because ultimately, if we're making it easier for provider to deliver sustained and better care through value-based care, then health systems are interested, small physician practices are interested, but also the health plans are interested. This is one of those, value-based care is one of those rare and awesome opportunities where, if done well, value-based care, all parties benefit. Right? The health plan holds the most risk typically. So therefore, if we're doing value-based care, they benefit. The provider owns a portion of the risk. If they do better, they benefit. Ultimately, doing prospective care is better for the patient. So all stakeholders benefit if done well. So we started with providers, solved the workflow, solved the technology problem, and designed a tool that is highly usable. 2024, we are growing in our health plan partnerships as well, which gives us a different opportunity, similar end user need, but a different opportunity to serve communities of caregivers, which is very exciting for us, and allows us to serve an entire population or community in partnership with a health plan partnership. So we're really excited about that in 2024. The second component we're doing is we're starting to move beyond just risk adjustment and HCC recapture and HEDIS and STARS, which has been our priority: quality, HCC recapture, and identifying underlying conditions. We're starting to move into AI associated with predicting negative patient trend, to be able to alert physician to something they would know if they had unlimited time and were perusing charts, but to proactively indicate there's a risk of a cardiac event, a risk of a COPD exacerbation coming for this subset of your population of patients. Again, towards that end of having a call center call out, not receive. So notifying them so they can be more involved. I think we're really excited about those components as well, and furthering that part of our effort.
That is awesome. Well, definitely a daunting task that you've taken on, and I wish you tremendous continued success with executing those goals. Where can people find you, Kevin?
Yeah, our website is curationhealth.co. That is an easiest way to find us. But feel free, we welcome conversations, even if it's not associated with a partnership. We're really invested in trying to further value-based care and how it performs on the outpatient side of the world. So we always welcome any and all conversations of like-minded individuals.
Love it. Well, Kevin, thank you so much for spending some time today. This was awesome.
Pleasure. Thanks for having me.